we'll do just that. Okay. Assalamu alaikum and hello everyone. My name is Samar Naqvi, and Myla gave such a lovely, detailed introduction to everybody. It's a pleasure to be here today and be a part of this. I see a lot of people joining in, and I hope this session is going to be useful, and it's already been a learning opportunity for us, and I'm sure it's going to be for the participants joining in. So what we will be talking about today will mostly revolve around the Karachi Down Syndrome Program, this organization that was set up about 8 years ago by this very young couple that happened to have a child with Down syndrome. And while they couldn't find the resources here in Pakistan, they started to look abroad to different, to the developed world, to the global north, and they got a lot of services there. They understood Down syndrome over there, and then came back and set up this organization so that no other family would have to go through what they went through when they had a child with Down syndrome. And to start out with, I think we're going to play a short video that speaks a little bit about the capabilities of individuals with Down syndrome and how we see them if we were to look at them as part of an inclusive society. And then we will move on to handing the floor to Tarkhis. Tarkhis is the mother of Sila. Sila is a very beautiful, almost 5-year-old with Down syndrome, and she's I mean, Talkhis can keep speaking about it, but her major identity is she's very proud to say that she's Umme Sila, which is the mother of Sila. So we'll hand over the floor to Talkhis to speak a little bit to her experience. So Zainab, if we could play the video, and then Talkhis, if you could take it from there, then we will speak a little bit about KDS.
وہ کہتے ہیں نا ہم سب کو اپنا بوجھ خود ہی اٹھانا پڑتا ہے. میں بھی اپنی زندگی ہمت، نظم و ضبط اور پرعزم حوصلے کے ساتھ گزار رہا ہوں، اور مجھ سے یہ طاقت کوئی نہیں چھین سکتا.
میری امی مجھے اسکول بھیجتے وقت پریشان رہتی تھی، لیکن اب وہ جان گئی ہیں کہ مجھے اسکول سے کتنا پیار ہے. دوستوں کے ساتھ کھیلنا، پروجیکٹس پہ کام کرنا، کانسرٹس میں حصہ لینا، اور ہمیشہ سیکھتے اور بڑھتے رہنا.
میں بڑا ہو کر عمران خان یا وسیم اکرم کی طرح بننا چاہتا ہوں. سب لوگ میرے باؤنسر سے ڈرتے ہیں، اسی لیے وہ چاہتے ہیں کہ میں انہی کی ٹیم میں کھیلوں.
ہر روز میں اپنے مقصد کے حصول کے لیے سر اٹھا کے نکلتی ہوں، اور سر اٹھا کے چلنا مجھے اچھا لگتا ہے، کیونکہ مجھے پتا ہے میں جو چاہوں گی وہ پالوں گی.
مجھے بیکنگ کرنا بہت اچھا لگتا ہے. ہمارے معاشرے میں کھانا کھلانے والے کی بڑی عزت ہے. میں بھی ذرا دیکھنا چاہتا ہوں کہ کھانا کھلانا کیسا لگتا ہے.
مجھے یقین ہے کہ ٹیچر بننا سب سے عظیم پیشہ ہے. سب لوگ ٹیچرز کی عزت کرتے ہیں، اسٹوڈنٹس ان کو چاہتے ہیں، والدین ان کی قدر کرتے ہیں. جب میں ٹیچر بنی تو ایسا لگا جیسے دل کی ہر تمنا پوری ہو گئی ہو. رنگوں کی ایک زبان ہوتی ہے، رنگ باتیں کرتے ہیں. میں وہ زبان جانتی ہوں، اور میں وہ آواز دنیا تک پہنچانا چاہتی ہوں اپنے برش سے.
کون سوچ سکتا ہے کہ ایک باریک دھاگے سے اتنے خوبصورت تانے بانے بنے جا سکتے ہیں. شاید ہر بڑے کام کی شروعات چھوٹی سی ہی ہوتی ہے. لوگ سمجھتے ہیں کہ جو بچے ڈاؤن سنڈروم کے ساتھ پیدا ہوتے ہیں
وہ اپنی زندگی بھرپور طریقے سے نہیں گزار پاتے، ان کی زندگی میں کچھ کمیاں رہ جاتی ہیں.
ایسا مشکل تو ہے لیکن ناممکن نہیں. صحیح توجہ، دیکھ بھال اور تربیت کے ساتھ یہ بچے اپنی تمام خواہشوں کی تکمیل پا سکتے ہیں.
یہ بچے اپنے جذبے سے تمام صلاحیتوں کو اجاگر کر سکتے ہیں. مسلسل مشق، محنت اور تربیت سے زبردست کامیابیاں حاصل کر سکتے ہیں.
اور دوسرے بچوں کی طرح یہ بھی اسکول جا سکتے ہیں اور اپنا مستقبل روشن کر سکتے ہیں.
یہ دوست بنا سکتے ہیں، کھیل سکتے ہیں، और अपने कहकहों की गूंज से मोहल्लों को रौनक बख्श सकते हैं।
इनको अपने आप पे नाज है और वो दूसरों के रहमो करम के मोहताज नहीं।
और अपने हुनर के इस्तेमाल से अपने लिए और अपने घर वालों के लिए एक बामकसद जिंदगी गुजार सकते हैं।
ये आने वाली नस्लों के लिए एक मिसाल बन सकते हैं। इनका फन दिल जीत सकता है, इनके रंग खुशियां बिखेर सकते हैं और ये कामयाबी की हर बुलंदी छू सकते हैं।
और अगर इन्हें मौका मिले तो ये भी बाकी सब की तरह अपनी जिंदगी भी खूबसूरत बना सकते हैं। डाउन सिंड्रोम से मुतासर अफराद
एक खुशहाल जिंदगी
और एक रोशन मुस्तकबिल के मुस्तहिक हैं।
तो आइए इनको मिलकर एक ऐसी ही जिंदगी फराहम करें।
Thank you. We could see the smiling faces and loving the love. This is, and I think no better time to hand over the floor to a mother who's actually experienced a lot of this and the perspectives and the stigma from society and how she's come through. So Talhis, over to you. Talhis, आवाज नहीं आ रही.
Assalamualaikum.
Walaikum salam.
Am I audible now?
Yes.
Okay. This is Talkhis Adil, mother of Sela Adil, who is going to turn, inshallah, 5 years old on 2nd August 2022. I gave birth to Sela in 2017, and I had an elder child who is mashallah 7 years old, and she was one of the very smartest kid, very intelligent, achieved most of the milestones very, very, very early. I used to hear कि ये तुम्हारी बच्ची तो बहुत ही ज़्यादा smart है. And then I delivered Sela in 2017, or right in the labor room, I got to know that she has Down syndrome. I did not know the D of Down syndrome. I was clueless. I was shattered. I was devastated because doctors were telling me that she's having a genetic disease which we call Down syndrome. So later, it was confirmed by a senior pediatrician, and Sila's health started deteriorating. She had 3 holes in her heart, and she was shifted to ICU. She had VSD, PDA, and PFO. I hope you all can hear me clearly, right? Okay. That was the time when I was thinking about, will she be able to hear? Will she be able to talk? Will she be able to stand? Will she be able to communicate? Mainstream school mein ja sakegi, nahi ja sakegi. These were the thoughts. But once I got to know that she may not survive, हो सकता है कि उसकी जान चली जाए because उसको heart conditions हैं. उस point पे I started making dua that I want my child back. मुझे वो वापस चाहिए, मैं उस पर मेहनत कर लूँगी. I'll give my 200%. मेरे पास जो भी जितनी भी skills हैं मैं उस पर apply कर लूँगी. But I want her back. I want her back alive. जिंदा चाहिए मुझे. So alhamdulillah, somehow she survived. She stayed in ICU for like 10 days, but she came back to us. Alhamdulillah. First initial 6 months were very, very, very tough because उसका जो वो heart conditions की वजह से हमें उस पर बहुत ही ज़्यादा जो है वो close monitoring और बहुत ही vigilantly उसको देखना पड़ता था कि किसी वक्त कहीं वो उसका saturation low ना हो जाए और कोई और problem ना हो जाए. So I used to stay at home 24/7. कोई नींद नहीं, कोई कुछ किसी भी किस्म का रेस्ट नहीं. मैं और मेरे हस्बैंड पर always on our toes कि बस किसी वक्त भी हमें हॉस्पिटल जाना पड़ सकता है. उसी 6 months के दौरान I searched Down syndrome internet पे, and I got to know about KDSP. The first link appeared on my screen was KDSP. उस वक्त भी मुझे क्लू नहीं था what KDSP is. I contacted them और मुझे पता चला कि आप अगर आके विजिट करें तो आपको पता चलेगा कि हम क्या कर रहे हैं. I visited KDSP and they told me कि आपको फौरन ही जो है वो स्टार्ट कर देना चाहिए थेरेपीज की, ऑक्यूपेशनल थेरेपीज की, स्पीच थेरेपीज की, फिजिकल थेरेपी. मुझे थोड़ा सा इट वाज समथिंग स्ट्रेंज फॉर मी बिकॉज इतने छोटे बच्चे की क्या फिजिकल थेरेपी होगी और क्या ऑक्यूपेशनल थेरेपी होगी. But deep down inside, I made a promise that I will follow whatever her therapist say. मैं सोसाइटी को, मैं लोगों को, मैं इन सबको नहीं देखूंगी, बल्कि मैं देखूंगी जो उसके थेरेपिस्ट कह रहे हैं. So when she was 1.5 months old, we joined physical therapy. और उस वक्त मुझे याद है वो कितनी सी थी. She was 2.6 kg और almost 3 kg की थी जब उसको यूं करके वो लिफ्ट करते थे और उसकी एक्सरसाइजेस करवाती थी her therapist Memuna at KDSP. और मैं घर आके 50 repetitions, 100 repetitions I used to do at home. और 24 hours में से जो है वो 6-7 घंटे मुझे सिर्फ थेरेपीज पे लग जाते थे या उसका रिसोर्स कलेक्ट करने में लग जाते थे. But I did not give up. फिर उसके बाद हमने उसको जब वो 4 months की थी हमने उसको ऑक्यूपेशनल थेरेपी के लिए एनरोल कराया. When she was 6 months old, we enrolled her for speech therapy. I was mocked, I was humiliated कि 6 महीने की बच्ची तो आम बच्ची बैबल करती है, आप उसको क्या बुलाना सिखा रही हो अजीब, you're doing something very weird. But I did not listen to anybody. I used to take my kid, me and my husband. The biggest support I had was still the biggest support I have is my husband. और हम दोनों ने मिलकर जो है वो इसकी थेरेपीज जारी रखी. By the age of 18 months, she started walking. By the age of 6 months, she started sitting. When she was 4 months old, she अपनी neck hold कर ली थी. She was doing everything a typical child does. So I was very happy and very satisfied कि चलो early intervention का फायदा हो रहा है. KDSP did a lot for us. When she turned 1.5 years old, हमने उसका CBC कराया. We found out कि उसके CBC में कुछ platelets का issue है, WBC का issue है. फिर हम 6 months तक उसका रिपीट करवाते रहे CBC, बट जो है वो कुछ भी क्लियरली फिगर आउट नहीं कर सके. एंड डॉक्टर सलमान किरमानी वाज हर पीडियाट्रिशियन, स्टिल ही इज हर पीडियाट्रिशियन. और he kept giving us hope कि कुछ नहीं होगा, don't worry, everything's gonna be perfectly fine. पर कहीं ना कहीं ये डाउट था कि कुछ ऐसा है which is not right. When she was 2.5 years old, हमने बायोप्सी करवाई because just to be on the safe side हमें करवा लेनी चाहिए, ऐसा डॉक्टर ने हमसे कहा. और बायोप्सी में जो है वो कुछ भी नहीं आया, it was inconclusive. But 2.5 years से लेकर 2.7 years तक उसकी CBC ऐसे ही रही. Everything was deranged, WBCs, platelets and hemoglobin. When she was 2.8 years old, finally biopsy ने हमें report दे दी that she had leukemia, AML. और उसके बाद फिर that was the point then again we were clueless, we were shattered, we were heartbroken. We did not know where to start from, where to go, किससे हेल्प मांगे, कैसे करें, because जो हम जानते थे leukemia का treatment especially in Pakistan is very 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 expensive. हम कैसे इसको जो है वो अफोर्ड कर पाएंगे, प्लस सिला जो भी 3 साल की भी नहीं हुई वो कैसे ये सारा ट्रीटमेंट बेयर कर पाएगी. बट अगेन द ऑर्गेनाइजेशंस जो हमारे साथ थी उस वक्त, KDSP अगेन और आसान हॉस्पिटल, इन दोनों ने मिलकर हमारा साथ दिया. And Sila stayed in hospital 9.5 months. Or Alhamdulillah, she is completely recovered now. It's been 2 years post-cancer treatment. Alhamdulillah, she's in a mainstream school. She's doing great. She speaks fluently. She does everything what my elder child does. She is completely potty trained. She eats herself. She dresses up herself. and we all are very, very proud of her. Secondly, पाकिस्तानी सोसाइटी के हवाले से अगर हम बात करें तो जब मुझे पता चला था कि मेरी बेटी को डाउन सिंड्रोम है, मुझे ऐसा लगता था कि the society we live in is not going to support us. Nobody is going to accept my child. Nobody is going to include her in any environment. वो parks हो, वो hospitals हो, वो schools हो, कहीं भी जाएगी तो उसको ऐसी नजरों से देखा जाएगा कि जैसे ये किसी और planet से आई है. But alhamdulillah, मैं इसका बहुत सारा credit KDSP को दूंगी that they spread awareness like anything. और उसकी वजह से over the period of 5 years, क्योंकि मेरा experience इन्हीं 5 years का है, बहुत कुछ change हो गया. Change in the sense कि अब लोगों को पता चल गया है कि अगर किसी का बच्चा सिर्फ डाउन सिंड्रोम नहीं, स्पेशल नीड्स है, तो उन्होंने किस तरह से कम्युनिकेट करना. नॉट 100%, बट सोसाइटी को अब ये समझ में आ गया है कि आपने अगर किसी स्पेशल बच्चे को देखना है तो उन्होंने किस तरह से उसको ट्रीट करना है. वो स्ट्रेन और वियर्ड जो नजरें होती हैं, वो स्टेयर्स होते हैं, वो अल्हम्दुलिल्लाह कम हो गए हैं बहुत हद तक. इंक्लूसिव सेटअप्स बहुत ज्यादा अब मुझे नजर आने लगे हैं, जो पास्ट 5 years में मैं देखती थी कि पेरेंट्स बहुत परेशान हैं कि अपने बच्चे को कहाँ पर एडमिशन दिलाएं, लेकिन अब विद द पैसेज ऑफ टाइम बहुत सारे इंक्लूसिव स्कूल्स हमारे सामने आए हैं. द ओनली लैकिंग जो मुझे नजर आई पास्ट 5 years में वाज लैक ऑफ अवेयरनेस, क्योंकि जब तक मुझे नहीं पता था कि मेरी बच्ची को डाउन सिंड्रोम है, आई यूज्ड टू से कि these kids are abnormal या रिटार्ड हैं या इस तरह के वर्ड्स यूज किए जाते थे कि शायद कुछ भी नहीं कर सकते. लेकिन जैसे ही मुझे मेरी बेटी मिली, मुझे अवेयरनेस आई, मुझे आगाही मिली, तो मैंने अपने साथ साथ जो मेरे से जुड़े हुए लोग थे मेरे फैमिली में, मेरे पेरेंट्स, मेरे सिबलिंग्स, उनको मैंने समझाने की कोशिश की कि क्या है. अब माशाल्लाह से मैं खुद फेसबुक के ऊपर ग्रुप्स हैं, बहुत सारे मेरी कनेक्शंस हैं जिनसे मैंने काफी सारे लोगों को अवेयरनेस दिया है. मुझे आज भी याद है कि जब सिला वाज 2 years old तो मेरे पास एक मदर ने मुझे मैसेज किया था और उसने कहा था कि her father उनका बेटा था, his father has abandoned him और मैं अकेली रहती हूँ और मुझे समझ नहीं आ रहा कि मैं क्या करूँ. उस वक्त मैंने उनसे सिर्फ एक बात की थी, फर्स्ट यू नीड टू ओन योर चाइल्ड. अगर आप खुद उसको ओन करेंगी तो सोसाइटी भी ओन करेगी. अगर आप खुद ही उसको डिसओन कर देंगी और छुपाती फिरेंगी. तो फर्स्ट टाइम उसने अपने डीपी पे अपने बच्चे की तस्वीर लगाई थी एंड आई वाज ओवर द मून कि यार देखो मेरे समझाने की वजह से इतना हुआ कि उसने अपने बच्चे को ओन किया. अब माशाल्लाह से उसका बच्चा भी एक मेन स्ट्रीम स्कूल में जा रहा है एंड शी इज प्राउड ऑफ हिम. तो अवेयरनेस इज द मेन थिंग. ऐसा नहीं है कि पाकिस्तानी सोसाइटी के अंदर सारे ही लोग जो है वो बहुत ज्यादा रूड और हार्श या उन्हें सेंस नहीं है. इट्स जस्ट कि उनके पास अवेयरनेस नहीं है. अगर आप अवेयरनेस दें, उनको बताएं कि ये चीजें कैसी हैं, आपने कैसे ट्रीट करना है, कैसे बिहेव करना है, तो things can definitely improve. Thank you so much.
Thank you, Tarhees. I was again, the hearts and the smiles speak for themselves. So Tarhees also plays, without realizing it, she plays a very important role for us as well. Every now and then we're in the middle of the workday with a bunch of things happening, very stressful, and she's gonna send a really short video of Sila, and you see the smile over there in these pictures as well, and she's doing something fun, and it just motivates us like anything. And she keeps doing that. She actually knows when to send it, so it's sporadic, it's spread out at a perfect time too.
She is actually sleeping at the moment. Otherwise, मैं लेकर आती हूँ उसको. She's going to wave you all, or she's going to make your day.
Absolutely. All right. So and continuing from there, I think just to let everybody know in its entirety what the Karachi Down Syndrome Program, KDSP, does as an organization. So oftentimes, as Tarhees pointed out, when mothers and caregivers and parents come into KDSP, they're full of a lot of feelings, and most of those feelings we try to put on those slides, and we sit them down. We sit them down and talk through their grief. Some of them are in denial. There's feelings of helplessness, loneliness, anger, fear, so much there. We sit them down, we speak to them for a good hour and a half, and try to tell them that their child too will have a beautiful contributing life in this society, inshallah. And we're going to be there with them every step of the way. We're going to hold their hand. We try to give them, we embrace them. And when we say we embrace them, we metaphorically embrace them. And sometimes it happens literally as well. But that's that reassurance, so that's that sense that they get when they come to KDSP that we've got them covered in all ways. And we try to describe what we do as an organization with this one acronym that we use. We call it the Kashti. Kashti is translated as a boat. In English, it's a boat, where we tell the families too that the waters up ahead might be choppy. There also might be calm seas sometimes, but it's just about holding strong and being your child's biggest advocate. And we're there to facilitate in all ways. So KDSP is that one-stop solution where families and individuals with Down syndrome can get all that they need for their child to have a value-adding, contributing life as well. And each of the alphabets in the word Kashti then stand for each of our areas of service. And these are again in Urdu, which I'll translate in English as well. But K is for Khandani Sahara, which is all our family support initiatives. A is for Agahi, which is all our awareness campaigns and all our awareness programs. S is for Sehat, which is healthcare. For healthcare, we partner with AKU and Indus as well. And we, Dr. Kirmani sitting here, he will be able to speak about that at length as well. H is for Hunar, which are all our skills building programs. T for Talim, which is all our education programs. And I for Ibtidai Bunyad, which are our therapies. So early childhood intervention, all occupational, speech and physical therapy. So in its entirety, KDSP is a Kashti, that boat where parents, once they're on board, the journey up ahead, we'll be with them all the way through. And just to get into these areas a little bit, just to talk about the resources that are there in Pakistan and that are available. In these 6 areas, for families, we try for them to have all the information that they might need for their child to grow up to be an independent member of society. We give emotional support groups. We also have resource packs for them. We have a program called Hamrahis, which is parent peer counseling, where parents kind of provide that support to each other, as opposed to just us providing that for them. And we also have financial support for families. For our early childhood intervention, we mentioned physical speech therapy and occupational therapy happen every week. So about 450 sessions are scheduled weekly with about 28 therapists that we have. Also, I may not have mentioned this, but our family network, the individuals with Down syndrome and the families that are associated with us are about 1,550 at this point in time. Then we have all our education-based programs. Education is where we cover our children between the ages of 2 to 3 study at the KDSP preschool, where we make them school ready so that they can then be a part of mainstream schools. We have a network of about 15 partner schools in Karachi, where children with Down syndrome, after going through the preschool at KDSP, study alongside typically developing children at these mainstream schools. And we try to make them as inclusive as possible. We also have after-school programs. We have homeschool programs. Under the ambit of healthcare, we partner up with AKU that has a team of specialized doctors who are responsible for the Down syndrome clinic. Dr. Kirmani leads that. That's exactly where all our children's healthcare needs are addressed. We also have healthcare camps. We have developmental pediatric clinics at KDSP. We've started up a behavior therapy program as well. Amongst the ambit, when we talk about skills development, we focus very heavily on training our young adults to learn a skill. We also have them prepare and make handicrafts, which we sell on their behalf. And then 100% of the proceeds go back to them so that they get that sense of being able to now contribute towards their households as well. Like one of the younger adults purchased a bike where now he goes to get grocery from the store. So you know, it kind of breaks the stigma around individuals with Down syndrome in Pakistan as well. There's been some form of sheltered employment that has started out as well. We have some young adults with Down syndrome working with different organizations for a short duration of time. And then there is all our awareness-based initiatives. So this is in its entirety what KDSP does. And while we try for us to be a holistic service provider, there's still a lot more that we wish to offer, and there's still a lot more we can offer. It's only been 8 years since we've been working, but families have a lot of trust in us, and they expect a lot from us too. And which is why we want to keep adding to make sure that we're fulfilling those expectations as well. So moving on, I'm just going to go over very quickly as to what more we would like for KDSP to offer as well. So while we have these resources, wherever we struggle or wherever KDSP doesn't have a resource within the organization, what we try to do is connect them with partner organizations so that they can get that facilitation and help elsewhere, even if it's outside of KDSP. And there's this entire slide on all that we have in plan and all that we have in store, because all of this comes specifically from the families. They raise those concerns and we ask them as to what they need. So one of the major concerns that families kind of keep speaking about is what happens to our child after we are gone? Where do they go? Because we don't have that kind of culture where there are many sheltered homes or secure community living spaces. That's all that we want to do, and that's all what we want to provide. I realize we're also running out of time, so I'm just going to wrap up here and kind of try to conclude with this this understanding that because we're familiar with the range and intensity of the concerns that families and caregivers of children with Down syndrome face, we also realize that there's a commonality, something that they're all looking for, something they're all seeking. It's reassurance. All they may need is for someone to tell them it's okay, or that it will be. Somebody to offer them solutions, to acknowledge the progress they've made, to appreciate the efforts and the fruit that their labor shall bear. They're all in pursuit of an answer, and they're all searching for hope. And we at KDSP attempt to provide that day in, day out. If it in its entirety, we are the organization that tries to provide that hope to the families so that they can then be the biggest advocates for their children. I'm going to wrap up here and let the next speaker go. Thank you so much for listening to us. Zainab, we might have to hand it over to.
Okay, looks like Zainab handed it back to me. But Yusra is next, right?
Yeah.
Okay.
Yes.
Okay, I'm gonna hand it over to Yusra. Thank you so much, Tulfis and Samar. That was just an amazing presentation. It pulled on my heartstrings. I'm sure it pulled on others as well. And thank you, Tulfis. I was just like to briefly echo some of the comments that we received when you were presenting, that you're an extremely brave mother, and what you said about owning your child and advocating for your child. Like, really, you hit the nail on the head. Thank you so much for sharing.
Thank you all so much for sharing. And Thank you, Myla, for the great introduction. So everyone, my name is Yusra, and me and Ambreen are going to do a presentation that focuses more on the genetics of Down syndrome and some of the features and characteristics that are seen in those with Down syndrome. So to get started, our outline for this presentation is we're going to go over just the basics about genetics and chromosomes, talk about the specific types of Down syndrome, the causes of Down syndrome, and then Ambreen will go over the prenatal and physical features and an overview of some of the medical concerns. So first off, let's talk about what is genetics. So varasat kya hai? So when you're thinking about genetics and inheritance, genetics or geniat is really the biological study of inheritance. So to put this into some context, let's think about this in terms of a family. So here is an example of a family tree. At the top of the tree, you can see are the parents.
We can't see the slide, sorry. We're just on the first one.
You're on the first slide?
We can see the family tree now.
Oh, okay. Maybe it was lagging a little bit. Okay.
Sorry about the technical difficulties, Yusra. If you don't mind, could you record it on your computer as well, just your bit?
Oh, yes, let me do that.
I see it is recording.
Yeah, it says it's recording.
Okay, we're good, thank you.
Okay, sorry about that. So just to get back into it, so this is an example of a family tree. At the top of the page, you can see there are two parents who have 3 children, and 2 of those children have grandchildren. So when we're thinking about genetics in general, we know that every person has 2 sets of genetic information. So here, the father has a set in blue and a set in purple, and the mother has a set in yellow and a set in green. And whenever we're thinking about inheritance or passing down genetic information, a child will receive 1 set from each parent. So that's kind of what the colors show in this presentation. Here, the daughter receives 1 green set from mom and 1 purple set from dad. The other son receives
Sorry,
one.
Yusra, we don't see those.
I'm sorry about the lagging. It's showing up on my screen.
There we go. They showed up.
Okay. How about, do you see all the images now?
Yes.
Okay. Okay. So as you can see here, now the grandchildren each receive 1 set of genetic information from each of the parents. Now, once we involve the grandchildren's other set of genetic information, they should be receiving 1 set from each of those parents. Now, in this picture, I want to reiterate that it is important that everyone has 2 sets of genetic information. However, what happens when someone like this grandchild in this photo has an extra set of genetic information? And that's what we're going to focus on today. So on average, human beings have 23 pairs of chromosomes. As you can see in this picture, there are two pairs, and each one comes from one parent, one comes from another parent. So for example, parent 1 passes down 23 chromosomes, and parent 2 would pass down 23 chromosomes, resulting in a child with a total of 46 packages of genetic information. However, in a child that has Down syndrome, they have an extra pair. So one parent, or an extra chromosome. One parent is passing down 23 chromosomes, and one parent is passing down those 24. This results in 47 total chromosomes in all of their cells. And this can happen by chance, and we'll go into more detail about this. So this is an image of what a genetics makeup of a child with Down syndrome or a person with Down syndrome looks like. If you can see at the bottom of the screen, there is an extra chromosome 21.
Sorry,
Yusra,
Yusra,
can't see
we are
any
not
of
seeing
the
anything. Your slide is stuck.
Sorry. So here's what we're gonna do. Sorry about technical difficulties, everyone. So you start try getting out of the slideshow mode. I think it may have something to do with your slideshow mode.
Okay.
So if you go out of your slideshow mode and try to go back to the inheritance picture, and then unfortunately we may have to start over.
Oh, my apologies. Okay. Let's see. Let me try refreshing this. It might just be because it's Google Slides. Let me try
Yeah,
refreshing.
if you want to, instead of going into slideshow mode, keep the slides and keep moving the slides forward without having to go in the slideshow mode.
Okay.
Yusra, if it's easier, I have it downloaded so I could always present my screen. Just let me know.
Yeah.
That's a good idea.
Yeah, let's go ahead and do that. I think it's because it's on Google Slides and it might be lagging or just not working
Okay.
properly.
Will you make me a host?
Yeah, thank you so much, Ambreen.
And Yusra, go back to the pedigree slide because that's when it kind of got stuck.
There we go,
You did
Ambreen, you should be a host now.
So this second time would be even better. You did a wonderful job, so good job.
Okay,
Perfect.
we'll just
Okay.
jump back in. Thank you all for being patient with us while we figured out these technical difficulties, technology. All right, so when I was talking about the family tree, I was trying to emphasize that everyone has everyone is supposed to have two sets of genetic information. However, here at the bottom of the screen, you can see that one of the grandchildren has that extra purple genetic set of information. And when we're thinking about patients who have Down syndrome, they have an extra set of genetic information. Now, this is an image of chromosomes in an average human. It shows that there are 23 pairs present in the chromosomes in the average human. And each of these chromosomal pairs, you're getting one of them from each parent. So for example, this chromosome 21 at the bottom of the page, one of those chromosomes comes from mom and one of those chromosomes comes from dad. Now, now, when we're thinking about someone diagnosed with Down syndrome, they're getting 23 chromosomes from one parent and 24 chromosomes from another parent, resulting in a total of 47 chromosomes. And this is an image showing that they have an extra chromosome 21. Now I'm going to go into more detail about the different types of Down syndrome, because there are different ways that this chromosome 21 can be passed down. So the different types of Down syndrome that I'm going to go over is trisomy 21, translocation, and mosaic. So trisomy 21 is the most common genetic etiology of Down syndrome. It happens in about 95% of cases. And this image shows that this is where, in fact, there are 3 copies of this chromosome 21 apparent in each cell in the person's body. It's not inherited and it cannot be passed down from generation to generation, and its recurrence risk is about 1%. Then you get into the more less common genetic reasons for Down syndrome, such as translocation Down syndrome. This happens in about 3% of the cases where an extra or whole chromosome 21 is present, but it's not present separately. So here you can see there's an image. In the image, there's a box around the chromosomes 14. one of the chromosomes on the right looks a little bit longer, and at the tip of the chromosome, you can see some bending. That actually shows an entire extra information present on that chromosome 14. So that means that that chromosome 21 actually attached itself to that chromosome. Now, in this type of Down syndrome, we do see a pattern of inheritance, and it can be passed down from generation to generation. And the recurrence risk is about from 3 to 10%. Now, the least common scenario of Down syndrome is called mosaic Down syndrome. And when we're talking about mosaicism, it means that there's a mixture of normal cells and then a mixture of cells that have that extra genetic information. Now, as you can see in this image on the right, you can have low-level mosaicism, where there are just some cells that have that extra genetic information, or you can see a high-level mosaicism and anywhere in between. And so this case, or this explanation of Down syndrome, some may have a milder presentation, just depending on how many cells in their body are carrying that extra genetic information. It's rarely inherited, but can be passed down, and its recurrence risk is about less than 1%. Now we're going to go into a little bit more detail about the causes of Down syndrome and where that chromosome 20, that extra genetic information is really coming from. So to explain this, we have to think about whenever the body is dividing genetic information, there's a chance for that genetic information to not get separated properly. So here in the left, there is a box showing what that division is supposed to look like. As you can see, those two red chromosomes separate evenly, one into each cell. However, on the right side, you can see that on the right side of the left picture, you can see that these red chromosomes don't separate properly. And so that is what we call mitotic non-disjunction. And that is when that chromosome 21 does not separate properly and results in that extra genetic information. So what we do see is that we do know that the older a woman gets, there is an increased risk for this mitotic non-disjunction to occur. However, I do want to be clear that a woman at any age does have a chance that they can have a child with Down syndrome. However, because women are born with all of the eggs that they're ever going to have, these eggs also age as a woman ages. So as a woman is 10 years old, their eggs are 10 years old. And as a woman is 35 to 45, their eggs are as old as they are. And because these eggs are aging with them, the machinery that's able to separate those two chromosomes, there's an increased chance that machinery might not work as well. And so that is why we talk about advanced maternal age, there being an increased risk or chance for someone over the age of 35 to have this occurrence.
Thank you, Yusra. Just diving into the prenatal and physical features, जब हम अस्सलाम वालेकुम everyone, I forgot to say अस्सलाम वालेकुम, but जब हम देखते हैं, how can we diagnose individuals with Down syndrome? Sometimes we look at blood, sometimes we look at DNA. As Yusra covered, as an individual, जब माँ की age ज़्यादा होती है, there's a higher risk, there's a higher chance when a maternal age is higher, but we often see more Down syndrome in individuals who have children under the age of 35, because most mothers, when they have children, are under the age of 35. And any of the things that Yusra explained are at no fault of the mother or the father or whoever the chromosomes pass down through. It just happens by chance. So basically, Allah ki marzi when it happens. So looking at, the spectrum of features that we see in individuals with Down syndrome, a lot of them may look similar, have similar physical features, may act similar, but each person does have a unique or different ability. सारे बच्चे जो हैं, उनकी abilities, उनकी बातचीत, उनकी personality might be different, might be unique to them. And so when we look at some of these features, they're just common general features, but that doesn't mean every single child will have those features. It just means, broadly, what do we look for? Sorry, now nice. Okay. So prenatally, some of the common things that show up. So in ultrasound, when jo bacha maa ke pet mein hota hai, so you look at the ultrasound, and half or normal ultrasounds are seen in half of the times. We can see heart defects in about 50% of cases. और जैसे सलाह की अम्मी ने बताया हमें कि she was born with some heart defects as well. That can commonly be seen. Sometimes we may see other changes in the womb as well, जिसको हम congenital anomalies कहते हैं, and they could range from different findings. हर बच्चा जिसके पास डाउन सिंड्रोम जो prenatally diagnosed होता है, it's not consistent कि they always have a prenatal anomaly. This is just, again, generally what we see and what we suspect that an individual in the womb may have Down syndrome. So we call them ultrasound soft markers because, again, they're not seen in every patient or every rather child. And then also they're not seen in every single baby with Down syndrome. Some of these are very non-specific. So echogenic bowel is one of them, where when you do an ultrasound, the bowel, the intestine part, may show up more brightly on the ultrasound. And that could be something completely out of the ordinary, normal, not related to Down syndrome, or sometimes could be. Sometimes you may see urinary tract dilation if there's issues with the kidney. जब बच्चे की जो है गर्दन के पीछे देखते हैं, sometimes you could see thickened nuchal fold. Again, common for other conditions as well, but can be seen sometimes in individuals who have Down syndrome. Sometimes you may see echogenic intracardiac focus, again, a bright spot on the heart, not, again, something only in individuals with Down syndrome, but more commonly seen. And then, as I showed earlier, there could be absent or hypoplastic nasal bone in individuals as well. Some of the other more physical features when the baby is born may be some of the things that you have seen in pictures as well. Now, again, these are just general features. सारे बच्चों के different features होते हैं, और they still look like their family members, but they may have some of these other more common features that we see in individuals with Down syndrome. One of them would be the way their eyes are shaped. So you may see that their eyes are shaped more kind of upwards on the corner and then more downwards towards their nose. And then they may have a shorter neck. They may have these lines that are different in their hands. Again, an individual may have 2 creases versus 1 crease. They may have a more flatter nose, but again, they apni family ki tarah lagte hain bacche ye, but sometimes they may have these additional features. And then this is, again, as a medical professional, we often get very caught up with some of these medical features, but your baby is your baby. So if you have a child, we could list all these features out, but at the end of the day, that is your child, right? So I think some of these can get very medical, but this is just a picture outlining some of the features that may see in individuals, or especially a baby who's born with Down syndrome, and may help medical professionals diagnose an individual or a baby who's diagnosed with Down syndrome. And so some of the things I already went over, but they may have a congenital heart disease, they may have hernia of their umbilical cord, less muscle tone, things like that. And then sometimes they may have what we call sandal gap toe, so a little bit of space in between their big toe and the other toes. So what are some of the medical concerns that we see in individuals with Down syndrome? I think at the end of the day, the family who has a child with Down syndrome or the patient who is affected with Down syndrome are the experts. But medically, when we're looking at some of the things, we notice intellectual disability. Now, it could be anywhere from mild, जिस तरह हमने वीडियो में देखा, बहुत सारे बच्चे हैं जिनको डाउन सिंड्रोम है और बड़े, they grow up to be adults and they're holding jobs, they're living independently, and then it's a spectrum. So it doesn't mean that somebody has to fall here or here. People could fall anywhere in the middle here as well. And I think that's why it's so important to empower these patients and these families instead of stigmatizing them, as it was mentioned earlier. So there are also some milestone delays or developmental delays for individuals who have Down syndrome compared to typical range. Some of the more common is when they crawl, when they walk, their bowel control, etc. But at the same time, again, it's still a spectrum, and different individuals or different children may just be delayed for other reasons not related to Down syndrome, and vice versa. Again, looking at it very medically, there are different medical concerns that we can see. One of the common ones that actually was pointed out is small or increased risk for leukemia. And so that's one of the ones that we think of in individuals, as well as heart defects. Some of these other concerns, like intellectual or development disability, language issues, things like that, could be remedied by working with a physical therapist and occupational therapist, as we heard. And then sometimes they can have hearing issues, sometimes they may have issues with their eyes. Again, a pretty big spectrum of what we can see with individuals who may have Down syndrome. So that concludes our presentation. I will pass it on to Jennifer, who will talk more about how we diagnose it. Jennifer, you should be the host now.
Jennifer, we can't hear you. You might be muted.
Sorry. Thank you, though, to everyone. It's been a great talk so far, and I hope to be able to continue that. And just to confirm, everyone can see my slides and hear me. Okay, perfect. Well, I'm hoping today to be able to go over some of the screening and diagnostic testing options to be able to hopefully provide a good overview of just some of those options that are available. For this talk, when I'm talking about screening, really those tests are going to be the tests that we offer during the prenatal period, and are meant to really help identify those pregnancies that are at a higher or lower chance for Down syndrome. And then when we talk about diagnostic testing, these are going to be the tests that can be offered either during the prenatal period or after delivery, and are really more meant to provide that definitive diagnosis. So getting into the screening tests, again, these are typically blood tests that we offer during pregnancy. And there's really kind of two main tests that we offer. Prenatal serum screening was the first that was really on the market and available. This kind of encompasses a couple of different tests. So you may hear it as quad marker screening or integrated screening, which is a combination of blood and ultrasound. But from the blood draws with these tests, what we are looking at are different markers that are being made in the pregnancy. And we're focusing on a pattern of those markers. So which ones are being made more, which ones are being made less, and then is that pattern consistent with Down syndrome or the other conditions that can be included on the panel. The testing with like integrated screening does also include an early ultrasound. So it can also be a way to start looking for some of these birth defects a little bit sooner in the pregnancy. Overall, though, prenatal serum screening does tend to have slightly lower detection rates for Down syndrome compared to the other, like the non-invasive prenatal testing and screening that we'll talk about. And it also is usually blood draws done throughout the pregnancy, so within the first and second trimester. So time-wise can also take a little bit longer to get results back. Non-invasive prenatal testing or prenatal screening is then the other testing that is offered during pregnancy. Sometimes this will go by many different names as well. So NIPT, NIPS, cell-free DNA screening, and then most labs also have their own branded names for the test. So Panorama, Harmony, Maternity 21, all these different names you may hear are all referencing the same type of technology for testing. So with non-invasive prenatal testing, how this test works is we are looking at cells that have come from the placenta. And the idea is as those cells shed off, they enter into mom's blood where they break down. And now those chromosomes and the DNA from the placenta are in mom's blood. So different labs will analyze that DNA a little bit differently, but the outcome or the results would be to report either a high risk or a low risk or chance for Down syndrome or the other conditions included in those panels. Overall, while there may be slight differences in the performance when you look at different labs, overall, when we have a screen negative or a low risk result, those results are generally very reassuring, and most labs will quote about a 99% confidence. If you have a low risk result, that baby does not have Down syndrome. But with any of the screening tests that we talk about, the non-invasive prenatal testing, quad screening, integrated screening, any positive result, we would always recommend confirmation with diagnostic testing, just because false positives can occur. So overall, when we're thinking about screening, the main advantages to these tests are that they are non-invasive, so they don't carry the risk that we traditionally associate with the kind of prenatal diagnostic testing options. And like we mentioned, those negative or low risk results can have a very high degree of accuracy and be very reassuring. Also, screening is typically offered a little bit earlier in pregnancy than the diagnostic testing, so can be started as early as 9 weeks. And especially with cell-free DNA screening can really be offered anytime after that. So there is a lot of flexibility as far as the timing of when these tests can be performed. And again, if we're thinking about integrated screening, we're also getting the opportunity to start including ultrasound screening a little bit earlier in those pregnancies. When we start thinking about some of the disadvantages associated with screening, the main one is that this testing is not definitive. So it's really only designed to give us that kind of higher chance or lower chance result. And again, both false positives and false negatives can occur. So again, with any positive or high risk screening results, we do usually talk about confirmation with invasive testing to help confirm those results. And when we think about screening, there are going to be certain pregnancy types that are either just more complicated to offer screening for, or screening may not be available for. So certain things like a twin pregnancy or even a triplet pregnancy, screening may not be available for those pregnancy types, or the detection rates may be a little bit lower. So there are unfortunately going to be some pregnancies where screening may not be available or may not be the best testing option. And in particular, when we're thinking about the non-invasive prenatal testing, we really do rely on the amount of DNA that is in that blood sample to make sure that we're reporting out accurate results. And this can be influenced by a lot of different factors, so maternal, environmental, or even pregnancy risk factors. So there may be some women that we do have to try multiple times to see if we can get enough of that DNA to be able to test, or some women that we just unfortunately are unsuccessful with getting screening results for. And then we talked a little bit earlier about mosaicism as a type of Down syndrome that can create some complications when we think about screening. And in particular, with the non-invasive prenatal testing, the concern would be if that mosaicism is present in the placenta, but doesn't match the mosaicism that we see for the baby or match just the cells that we see for the baby. So in this example, it would be example, or in this picture, it would be example number 2 and example number 3, where what we have as far as the information in the placenta does not match the information that we have for the baby. So again, just another reason why this testing would be considered screening and may not be able to provide the definitive diagnosis for everyone. Moving on then to diagnostic testing. When we talk about diagnostic testing, the main difference is this testing is going to be performed on full intact cells. So with this testing, once the lab has those cells, we can run the same testing, whether that's done during the prenatal period or whether that's done after a child has been delivered. So there is the option to do the blood draw after delivery. But during pregnancy, the 2 main procedures that we reference when we talk about diagnostic testing are going to be chorionic villus sampling, or CVS, and then amniocentesis. And the picture on my slide is of the amniocentesis, but both tests are very similar in that we would be using ultrasound to help guide the procedure, and then using a needle to go in and remove cells from the pregnancy. With amniocentesis, we're really looking at cells from the amniotic fluid. With CVS, we are looking at cells from the placenta. So we're looking at slightly different sources for those materials, but where we go in with the needle and are removing those cells, there is risk associated with these procedures. And typically we talk about the risk for miscarriage. So definitely something to consider when kind of thinking about these as testing options. But once we have those cells, again, in the lab, we can then perform the same testing regardless of what procedure we've done. And kind of the main test that we think about with Down syndrome is going to be the karyotype. This is what gives us these images of the chromosomes that we've been kind of referencing throughout the talk. And really allows us to be able to look at not just the number of the chromosomes, but also the structure and where they're located. So being able to look to see if there is that translocation versus if there is not a translocation. So really those pieces of information that we can use to help determine how likely it would be to occur again in a family. And the other thing I would just mention with looking at the chromosomes is that we do look at all 23 pairs of chromosomes. So while we can definitely assess the risk for chromosome 21 and for Down syndrome, we're also able to look at a much kind of broader scope of other chromosome disorders as well. While karyotype is kind of the main test that we kind of talk about with any of our diagnostic testing, there are other tests that can be used either along with that karyotype or just as separate tests. Very briefly, just to touch on 2 of the more common that at least we offer during pregnancy, those are going to be FISH and microarray. Both of these tests are really good about being able to help us count or measure the amount of DNA that is present, but maybe a little bit limited in looking at the structure of the chromosomes themselves. But very briefly, FISH just allows us to quickly count the cells at a very early stage without getting that full picture of the chromosome. So it can sometimes help with timing of testing, whereas microarray is going to be able to look for small changes within the chromosomes beyond just is a full copy of a chromosome extra or missing. So while it definitely has that capability, it is looking at smaller changes as well. So overall, when we talk about diagnostic testing, the main advantage is that this is going to be a definitive diagnosis. So it really helps provide that definitive yes or no answer. And again, can help us identify those more rare cases of mosaicism or translocations. And the other kind of advantage is that it does allow us to look at a much larger scope of some of these conditions beyond just kind of Down syndrome or the more common conditions that are often included in screening. And again, the main disadvantage is this testing is going to, at least prenatally, carry risk. So we do overall consider the procedures to be safe because we consider that risk to be low, but the risk is present. So again, definitely something to be considering while thinking about testing options. And I would say one of the other disadvantages is that, again, prenatally, these tests have very defined time windows. So there is not as much flexibility with these testing as there may be with some of the other screening options. So just to provide a little bit of an overview of kind of the conditions that we've covered or the procedures, I should say, that we've covered in this talk. The big things I would always talk to patients about when I was working in clinic kind of come down to timing of the testing. Is the test considered diagnostic? And then really what conditions are included? So all things to really consider when trying to pick, is one test maybe a better option for another in any given situation? And of course, all of this balanced with, is someone comfortable taking risk or not during the pregnancy? And I think Aisha was going to help a little bit with the translation here for me at the end.
Thank you, Jennifer, so much. मैं तो बहुत जल्दी थोड़े से अल्फाज में उर्दू में का तर्जुमा करना चाहूँगी ताकि वो साथी जो इंग्लिश को पूरी तरीके से नहीं समझ सकते उनके लिए थोड़ी आसानी हो। तो ओवरऑल अगर आप देखेंगे किस तरीके से बच्चों को डायग्नोज कर सकते हैं डाउन सिंड्रोम के लिए, तो उसके लिए हमारे पास मुख्तलिफ ऑप्शंस होते हैं जब वालदा हामला होती हैं उस वक्त और जब बच्चा पैदा हो जाता है उसके बाद भी। तो हामला होने के दौरान डॉक्टर साहिबान खून के टेस्ट करा सकते हैं। दो मुख्तलिफ तरह के खून के टेस्ट मौजूद होते हैं। आपके डॉक्टर के पास जो भी ऑप्शन मौजूद हो वही ऑप्शन ठीक होती है। या तो एक होता है हमारा खून का टेस्ट जिसमें DNA को देखा जा सकता है, जो कि जीनियाती इंफॉर्मेशन जो जीनियाती मैटर होता है उसको चेक किया जा सकता है। दूसरे और केमिकल्स होते हैं जिनको भी टेस्ट किया जा सकता है। उसके अलावा अल्ट्रासाउंड भी मौजूद होता है। इन तरह के टेस्टों को जिसमें एग्जैक्टली नहीं पता चल सकता, सिर्फ इम्कानात के बारे में पता चल सकता है, आया बच्चे को डाउन सिंड्रोम होने के इम्कान कम है या ज्यादा है। इस तरह के टेस्ट को हम एक स्क्रीन कहते हैं, इंग्लिश का लफ्ज है स्क्रीन कहते हैं। समझ लें इस तरह से छांटी जिस तरह की जा सकती है कि एक तरफ छन्नी है और छान के एक तरफ दूसरी तरफ लाया जा सकता है। तो इस तरह से हम पता कर सकते हैं कि अगर किसी बच्चे को खून के टेस्ट से पता चलता है या अल्ट्रासाउंड से पता चलता है कि उसको डाउन सिंड्रोम होने के इम्कानात ज्यादा हैं, तो फिर उसकी यकीनी तौर पे टेस्टिंग दो तरह से की जा सकती है। जब माँ हामला होती है, दोनों टेस्ट के लिए एक सुई से कुछ या तो पानी या कोई और टिश्यू या चीज जो है वो माँ के पेट से बाहर निकाली जाती है और लैबोरेटरी को भेजी जाती है। फिर उससे कंफर्म कर सकते हैं कि क्या बच्चे को डाउन सिंड्रोम है या बच्चे को डाउन सिंड्रोम नहीं है। और फिर हम क्योंकि पाकिस्तान में इस तरह की चीज़ें हर जगह मौजूद नहीं होती हैं, तो ज़ाहिर सी बात है जब बच्चा पैदा हो जाता है तो उसके बाद भी उसका एक खून का टेस्ट किया जा सकता है जिससे कंफर्म कर सकते हैं। और उसके अलावा हमें तो वैसे भी पता है कि अगर डॉक्टर साहिबान उनका मुआयना करें तो उनको भी देखा जा सकता है कि हाँ भाई जो जितने भी हमें डाउन सिंड्रोम में फीचर्स नजर आते हैं वो आए इस बच्चे में मौजूद हैं कि नहीं है। और इस बात का दोबारा से ध्यान दिला दूं कि सब तरह के डाउन सिंड्रोम पास्ड आउट नहीं होते हैं, यानी कि पास्ड आउट का मतलब वालिदैन से बच्चों में नहीं आते हैं। तो इस चीज का इख्तिलाफ करने के लिए इस तरह को देखने इस चीज को देखने के लिए कि क्या ये वाला जो डाउन सिंड्रोम है इसकी क्या वो किस्म है जो हमारे आइंदा आने वाले बच्चों में हो सकती है कि नहीं हो सकती है, उस चीज को देखने के लिए ये बच्चे के पैदा होने के बाद खून का टेस्ट किया जा सकता है और उसके लिए डॉक्टर साहिबान आपकी मदद कर सकते हैं। So with that being said, I will now pass it on to Dr. Ajaz Ahmed. Dr. Ajaz, please take it away. And Jennifer, you made him host.
I just did. You should be host now.
Thank you, Jennifer.
Okay, thank you. Can you guys see my screen?
Yes, we can see it, but it's not in presenter view. Okay, looks like it is now. Good.
It's now.
Mhm.
All right.
And then you
Sabse pehle, Assalamu alaikum to everyone, and congratulations and kudos to KDSP for running such a great program, and Samar, Zainab, and Salman, thoroughly impressed with the stuff that's being done there. With that, and Salman, your permission, I know you take care of all the patients of Down syndrome that are associated with KDSP. I would like to just present some management guidelines that we follow here in the US. It's not necessarily something that's followed everywhere in the world, but just wanted to go over this with you guys. Important cheese, there's some important considerations that I would like everyone to understand that I think we've talked about it, that all patients with Down syndrome have the same genetic problem where there's an extra chromosome 21, but they may not have the same medical problem. They may have similar medical problems, but not the same. And I'll go over them with you. So not every child should be expected to have the same problem as the other child. And also, Ambreen has already touched on that even in the intellectual disability, there's a range. Most of them fall in the moderate to severe category. Some of them have milder intellectual disability as well, and those patients are more functional. We think some of them may have mosaic Down syndrome. That's why they are more functional, but sometimes it's not always the case. Medical issues, I will touch base on that there's such a range of medical issues. Also, the important thing to understand is the outcome of these children can depend on the availability of the medical care and therapies that are so important, and Samar outlined all the therapies that are being given to the children over there. Life expectancy of these children with Down syndrome has increased a lot. I think in 1993, it was about 30 years to now, it's about 60 years on average. So life expectancy has increased, and that's really due to the good medical care that is provided to these children. So it's very important that they do see their doctors and get proper care. Lastly, important to understand is regardless of the type of Down syndrome, either it's Down translocation or it's full trisomy, or if it's mosaic Down syndrome, we manage all the patients in the same way. It's not like if you have this, there should be followed differently. It's only important for recurrence risk, but as far as medical management is concerned, all of these patients are followed in the same manner. So that's important to understand. When I think of Down syndrome management, really, I would like to put them in 4 different buckets. That's the most important thing. One is family support. This is, we can't overemphasize the importance of family support in terms of management. And people have already talked about it, and Dr. Weil will also talk about it after my presentation, so I won't touch on it. The other bucket is the developmental and growth assessment. And that's something that doctors are not too involved with. It's the teachers, the schools, it's the therapist, and the nutrition at home, all of those things that help the child develop properly and have proper growth. But that's an important thing. The third is the medical assessment, which I will touch base on. And lastly, the children with Down syndrome themselves, what kind of life skills do they learn so that they can be more functional members of the society? And that's something also that depends on the therapist and the availability of different resources in different countries. I will mostly touch on the medical assessment and medical management of these patients. As far as this developmental and social assessment, one thing that is important to understand that many times when these children, babies are born, they have hypotonia. That means उनका जो बॉडी होती है उसके अंदर इतनी उनकी मसल स्ट्रांग नहीं होती, उनकी बॉडी बहुत लूज होती है और वो लूज होने की वजह से उनको टाइम ज़्यादा लगता है चलने में. They take longer to walk or crawl. Well, almost all children with Down syndrome do walk, and almost every patient that I have, walks, but it just takes them a little bit longer. So again, if you provide them physical therapy, that helps them a lot to achieve that much quicker. And also sometimes they may have fine motor skills problem where they may have issues with writing or drawing. So occupational therapy helps with that. And sometimes you may have seen children with Down syndrome who may have a tongue that is protruding, ज़बान बाहर निकली हुई होती है और शुरू में परेशानी होती है क्योंकि ज़बान के साथ प्रॉब्लम है या मुंह के साथ प्रॉब्लम है. रिलेटिव मैक्रोग्लॉसिया तो ज़बान बड़ी होती है, बट नॉर्मली उनका मसल टोन भी जो होता है जिसकी वजह से उनका मुंह खुला होता है और ज़बान बाहर लटकी होती है, जो वक्त के साथ साथ बेहतर होती चली जाती है. ये बेबीज में आप ज़्यादा देखते हैं. They may have speech delays, and mostly all children with Down syndrome do talk, but some of them have severe autism as well, and those are the children who do not talk, but many of them are able to communicate. Again, an important thing for speech problem is to make sure कि उनकी hearing check होती जाए. जो ईयर का कैनाल होता है वो छोटा होता है, उनमें ईयर इन्फेक्शंस बहुत ज़्यादा होते हैं. इसकी वजह से उनकी हियरिंग जो है, हम कहते हैं कि उनकी हियरिंग जो है कॉन्स्टेंटली हर स्टेज ऑफ लाइफ चेक होनी चाहिए, स्पेशली अगर बच्चों में ज़्यादा स्पीच डिलेज है. और ऑफ कोर्स अगर स्पीच प्रॉब्लम्स हैं तो स्पीच थेरेपी इज इम्पॉर्टेंट. बिहेवियरल प्रॉब्लम्स होते हैं बाज़ बच्चों में. बहुत सारी फैमिलीज हैं यहाँ पे, वो अच्छी तरीके से जानते हैं कि बच्चा कभी कभार किसी चीज़ पर अड़ जाता है and don't want to do that. So, those problems can be helped with ABA therapy, which is applied behavior analysis, or psychotherapy, or other therapists who are expert in dealing with children with Down syndrome. Some kids have autism and they need more attention. Uske alawa socialization, family relationships, sibling interaction, these are very important factors. Families बहुत ज़्यादा affect होती हैं, खासतौर पे जो दूसरे बच्चे होते हैं उनको कभी ये होता है कि माँ बाप हमारे उस भाई या उस बहन पे ज़्यादा अटेंशन दे रहे हैं और हम पे नहीं दे रहे हैं, तो उसकी वजह से प्रॉब्लम्स हो सकती हैं. इसकी वजह से पूरी फैमिली की थेरेपी इज़ वेरी इंपॉर्टेंट सो दैट एवरीबडी अंडरस्टैंड्स व्हाट्स गोइंग ऑन. उसके अलावा स्पेशल एजुकेशन और लाइफ स्किल ट्रेनिंग के ऊपर मैं बात कर चुका हूँ. As far as the clinical management is concerned, this is a report of the American Academy of Pediatrics that was just recently published, actually, May of 2022 in Pediatrics. This is the latest guidelines that we have for following children with Down syndrome. And I'll just touch base on those. बहुत details में है, but I just want you to know this as a reference. अगर आप लोग कोई patients को manage कर रहे हैं with children with Down syndrome, this would be a good resource for you if you are interested. As far as the medical problems are concerned, Ambreen already touched on quite a few of them. I just want to make sure that I just point out the few ones that are important. Hearing problems, like I said, almost 75% of these patients have hearing loss, which is big. So that's why what is recommended is that they should have a newborn hearing exam, और उसके बाद periodically उनकी hearing check होती जानी चाहिए. And then they may have vision problems, and there are all kinds of different vision problems that they may have, and it's about in 60 to 80% of the patients. So that is important to know that these patients should get an eye exam at the time of diagnosis or soon after birth. Sometimes they can have congenital cataracts, so it's important that they get vision exams. So यहाँ पे हम बच्चों को कहते हैं कि hearing exam or vision exams almost every year till the time they are at least 8 to 12 years old करते हैं. Sometimes they continue till 18. Other big thing is obstructive sleep apnea. Many of these kids have a very flattened nasal bridge, और उसकी वजह से उनका जो है जो सांस लेने का मैकेनिज्म होता है वो कॉम्प्रोमाइज होता है, तो उसकी वजह से जब वो सोते हैं तो खराटे देते हैं, कभी उनकी नींद पूरी नहीं होती. तो इसलिए बहुत इम्पोर्टेंट है कि इन बच्चों का स्लीप स्टडी कराई जाए, देखने के लिए कि if they have sleep apnea, because there are CPAP machines or other apparatus that they can use that would help them with the apnea. और अगर उनकी tonsils या adenoids बढ़े हैं तो उसकी सर्जरी भी की जा सकती है. ओटाइटिस मीडिया जो कि कान का इन्फेक्शन होता है, ये भी ज़्यादा कॉमन है, इसलिए पीडियाट्रिक विजिट्स में वो आमतौर पर चेक करते हैं. हार्ट डिजीज जो है अबाउट 40 to 50% ऑफ द पेशेंट्स में रहता है, तो इट्स वेरी इंपॉर्टेंट टू गेट एन एकोकार्डियोग्राम एट द टाइम ऑफ द डायग्नोसिस और सून आफ्टर बर्थ. मेनी टाइम्स यहाँ पे तो प्रीनेटली भी हो जाता है, लेकिन पोस्टनेटली बेबी पैदा होने के बाद हार्ट का अल्ट्रासाउंड कराना जरूरी है. जैसे मिस तलखीस ने बताया उनकी बेटी को हार्ट का प्रॉब्लम था सिला को और सर्जरी हुई थी, तो दैट इज वेरी इंपॉर्टेंट. बहुत सारे बच्चों को फीडिंग डिफिकल्टीज होती है इनिशियली और हाइपोटोनिया की वजह से 31 to 80%, तो इट्स वेरी इंपॉर्टेंट कि उनका फीडिंग असेसमेंट हो और उनको इफ नीडेड समटाइम्स कभी जी ट्यूब डालना पड़ता है, लेकिन उसके अलावा मेनी टाइम द किड्स आफ्टर थेरेपी दे स्टार्ट फीडिंग वेल, सो इट्स इंपॉर्टेंट टू कीप एन आई ऑन देयर एंड देयर वेट. कंजेनिटल हाइपरथायरॉयडिज्म जो है और थायराइड के प्रॉब्लम्स बच्चों में बहुत ज़्यादा कॉमन होते हैं, ये जो डाउन सिंड्रोम के बच्चे होते हैं. इसलिए ज़रूरी होता है कि इनका थायराइड चेक किया जाए, और थायराइड चेक करने के लिए TSH एक टेस्ट होता है जो पैदाइश के फौरन बाद किया जा सकता है. और यहाँ पे कहते हैं कि हम ऑलमोस्ट एवरी ईयर जो है वो थायराइड का TSH करवा लेते हैं, जस्ट टू मेक श्योर दैट द थायराइड इज वर्किंग प्रॉपर्ली. सीजर्स हो सकते हैं बाज़ बच्चों में. हीमेटोलॉजिक प्रॉब्लम्स की बात की, जो लुकीमिया के हवाले से सिला के अंदर there's CBC एक टेस्ट होता है, कंप्लीट ब्लड काउंट, जो कि किया जाता है राइट आफ्टर बर्थ. अगर उसमें वाइट काउंट सेल बढ़ा हुआ हो तो दैट इज अ ट्रांजिएंट एब्नॉर्मल myelophoesis, which is basically an increase in white cell count. If it's normal, many times it can be abnormal, but within 3 to 4 months it should go back to normal. But if it does not, then those children are at an increased risk for leukemia. So it's very important that this should be monitored. और leukemia की अगर उनका persistent है myelophoesis, so they should be monitored, and parents should be told about what are the signs of leukemia. Bleeding हो सकती है, या bruising हो सकती है, weakness हो सकती है, so they can keep an eye for that. उसके अलावा there are some autoimmune conditions that are common in these children. Atlantoaxial instability is about 1 to 2%. उसमें होता है कि गर्दन जहाँ सर और रीढ़ की हड्डी मिलती है, spine and the head where they join, there is instability there. तो अगर बच्चा आपका जिम्नास्टिक करने लगा या कुलाटी खाने लगा या स्पोर्ट्स में जाने लगा, so it's better to get that assessment done to see कि वहाँ पे लूज तो नहीं है उनका जो सर. और उसके लिए जो है अगर सर्जरी में भी जा रहे हैं, इंट्यूबेट करने के लिए हैं, तो they need to know कि उनके atlantoaxial instability नहीं है. As I said, about 7 to 19% of the patients have autism, and that is very important to assess. So those are the big things. तो मेडिकल इवैल्यूएशन जो मैंने खुद ही बात कर दी है कि सबसे पहली चीज़ तो होती है कि क्रोमोसोम करवाया जाए ताकि कंफर्म हो जाए डायग्नोसिस. उसके अलावा you can do a CBC, you can do the thyroid function test, hearing screen, eye exam, heart ultrasound, feeding and nutrition evaluation. और important thing is to see कि ये बच्चों को constipation हो सकता है, या sometimes उनका duodenal atresia या GI atresia होता है, तो क्या वो स्टूल पास कर रहे हैं सही से, उसकी असेसमेंट और स्लीप की असेसमेंट. ये जो चीज़ें हैं ये इम्पॉर्टेंट है आपको इनिशियल डायग्नोसिस के बाद करने के लिए. एक और इम्पॉर्टेंट बात ये है कि इनकी जब आप ग्रोथ का असेसमेंट करेंगे बच्चों का, तो इनकी ग्रोथ डिफरेंट होती है दूसरे बच्चों से. जैसे सिला के बारे में बताया कि शुरू में ग्रोथ उनकी बढ़ नहीं रही थी और परेशानी थी कि वो खा नहीं रही है और ये प्रॉब्लम. तो बच्चों का ग्रोथ चार्ट अलग है. डाउन सिंड्रोम का ग्रोथ चार्ट ये CDC की वेबसाइट है, सेंटर फॉर डिजीज कंट्रोल की US की वेबसाइट पे अगर आप जाएंगे तो वहाँ पे आपको ग्रोथ चार्ट्स मिल जाएंगे फॉर बेबीज विद डाउन सिंड्रोम. लड़कों का अलग है और लड़कियों का अलग है. इनका हेड circumference, इनका लेंथ, इनकी वेट, and these children should be monitored, and parents can actually print these out and they can monitor and dot पे इस पे एज होती है और कितनी हाइट है और कितना वेट है वो मॉनिटर कर सकते हैं. तो उनको खुद अंदाजा होगा कि उनका बच्चा वेट सही से गेन कर रहा है और उसकी न्यूट्रिशन सही है and ग्रोथ सही है. So this is important and you can just download it from the CDC website. In short, this is a little bit complicated slide. I don't want to go over this in detail. जो doctors हैं उनको ज़्यादा interest होगा इसमें. This is a little chart basically suggesting the schedule of health checks. तो जैसे कि मैंने बताया, thyroid का blood test birth से लेकर 6 weeks के अंदर करना चाहिए, eye check होना चाहिए, hearing check होना चाहिए, growth monitoring, heart defects. तो ये बता रहा है कि under 6 weeks तक special checks, under 2 years pre checks. And what needs to be done school age. Basically, it's the same things that need to be kept checked every time they visit a doctor. So that's important. This is also a table from a recent article that was published in 2022 in British Medical Journal. And it pretty much incorporates most of the American Academy pediatric guidelines. जो चीज उसमें इंक्लूडेड नहीं है वो मैंने पहले आपको बताया, एटलांटो स्टेबिलिटी का जो गर्दन का है उसका ख्याल रखना पड़ता है. और एक ये है कि इन बच्चों को आयरन डिफिशिएंसी एनीमिया भी हो सकता है. तो इसलिए वैसे तो पीडियाट्रिशियंस नजर रखते हैं बच्चों पे कि उनको आयरन डिफिशिएंसी एनीमिया तो नहीं है और उनका चेक करते हैं, मगर खासतौर पर डाउन सिंड्रोम के बच्चों को ये ख्याल रखें कि उनकी खुराक सही हो और उनकी आयरन डिफिशिएंसी एनीमिया को चेक रखा जाए. उसके अलावा दे हैव अ हायर रिस्क फॉर ल्यूकीमिया, स्पेशली जैसे मैंने बताया ट्रांजिएंट myelopoiesis, transient acute myelopoiesis वाले patients को. So those families should be sent to hematology oncology. यहाँ पे हम भेजते हैं so that they can keep an eye on them because there's a good chance, about 4% chance that they would develop leukemia if they have that. Generally cancers जो होते हैं इन बच्चों में कम होते हैं. That's a good news. Breast cancer, colon cancer वगैरह की में कम पाया जाता है. But the only thing that they've been reported is a slightly increased risk for testicular cancer in males. So for doctors who are managing children with Down syndrome, they need to keep an eye. It's just a simple testicular exam just to see if there is. It's still very, very low, nothing to be scared of. I'm just bringing it up because it's a little bit higher. इसके अलावा उनके skin infections हो सकते हैं sometimes because of not proper hygiene, and sometimes they just have dry skin and that needs to be taken care of. बहुत दफा बच्चे बता नहीं सकते कि उनको क्या problem है. So it's important for parents to keep an eye and make sure that our hygiene is proper. एक important aspect जो मैं touch करना चाहूँगा वो sexual exploitation का है, जिस पे हम आमतौर पे बात नहीं करते. लड़कियाँ होती हैं, लड़के होते हैं जो कि इस age के होते हैं, वो हमको यहाँ पे भी और वहाँ पर भी उनको उस environment में रखना होता है जहाँ पे they are protected environment. They are with people that they know and the people that the parents trust. Because of their intellectual disability, they are easily taken advantage of. So it's very important, खास तौर पर लड़कियों के लिए, और माएँ जो हैं, mothers who are here, who they know it very well, that this is always on the back of their mind. So it's important that they are protected. And also, जब लड़कियां, when they start their menses, it's okay to talk to the doctor about putting them on birth control pills, and that helps with the hygiene as well, because they are unable to care for them when they start their menses and periods. So it's important that that's something that is discussed with prepubertal girls. Parents should have that conversation with the doctor and maybe go and see an OB doctor and decide to put their children on birth control pills. Lastly, Alzheimer's disease is a little bit more common. About 30% of Down syndrome adults over 50 years may develop Alzheimer's disease and dementia, and that is something to be aware of so that they can be assessed properly and cared for. This is just basically a full table that is in that article in pediatrics that I have. So this is for doctors who are taking care of children with Down syndrome, or even for KDSP, if you want to print these out and hand them over to the parent, so they know exactly that birth up to 1 year, what test needs to be done, from 1 month up to 1 year, what test needs to be done, so they can keep checking that. That way they know that at least from the medical perspective, these things needs to be done. Again, this is what we follow here. It's different from different countries, and Salman is an expert over there, and he may do it differently over there, but this is generally what we follow. So this is very important. That's pretty much it for me. And I'll be happy to answer any questions with the panelists at the end of the session.
Thank you, Dr. Ajaz. That was excellent presentation. So if you don't mind, can you give the host privileges to, do you need to? I guess we don't anymore, right?
No, we need to give it to John.
I don't know.
No need. You can give it back to Myla, and we can have John talk.
Okay.
John, you're up next. There he is.
Sorry, I wasn't unmuted. If you will take it off screen share so that I can see my presentation on my computer.
I am not sharing my screen. What is everyone else saying?
Oh, I just made John the host.
Okay.
Okay, I'm not sure how to handle that.
John, do you see a little icon that says view?
It says what?
View. What exactly are you seeing right now? Because you can change your view if that's what you need to do.
Oh, view. Okay, no, that's not the problem. I need to get all, I'm still showing screen share, so I can't bring up my prepared remarks.
You can just hit the share screen button, and it will give you the option of which screen you want to share. And then
He doesn't need to.
He doesn't want to share.
He doesn't want to share. That's okay. What we could do, John, is if you want to, you can minimize the screen that you're on. When you hover over on the top left, no, not top left, top right.
No, it is. I never made it full. We discussed this yesterday. I never made it full screen, but I'm still having screen share on my computer, so I can't bring up. I can't. I'm sorry.
That's okay. We are not seeing your screen.
All right, I'm okay. I'm fine. Okay. Well, I am honored to have the opportunity to contribute to this case conference presented by the Pakistani Society of Medical Genetics. And before I get my relatively brief prepared remarks, coming at this point in the program, I want to make a few comments. A lot of what I have to say has been covered already and has been covered beautifully and admirably. I am really moved what the KDSP is doing. In some respects, what is happening now in Pakistan, mirrors some of what happened in the United States a long time ago, when genetic counseling was just being introduced, when understanding of Down syndrome was being more adequately disseminated, both medically and in terms of lay people's understanding. And if there's any way that I can contribute further to what the KDSP is doing, I would be very, very pleased to do so. The other thing I want to say is that from 1976 to 1986, I studied Down syndrome in the laboratory of Dr. Charles Epstein at the University of California, San Francisco. And to get technical for just a minute, I used two-dimensional polyacrylamide gel electrophoresis and other techniques to look at the levels or amounts of individual proteins and enzymes in fetal fibroblasts from both diploid individuals and trisomy 21 individuals, looking for gene dosage effects due to trisomy 21. Those were very early efforts that Dr. Stein pioneered, and of course, what is available, what can be investigated now is just amazing and marvelously further along than that. So I've seen the full, in some respects, full spectrum of that, which is moving from the medical and research perspective. The birth of a child with Down syndrome, especially if it is unexpected, changes the life of a family in many ways. Many questions arise. They include what medical treatments, if any, are needed now or may be needed in the future. What special care will my child need now and as he or she grows and goes through the many different stages of life? Will my child be able to have a normal life in terms of going to school, having a job, having friends, getting married, and having children? What will the various members of my family, of my husband or wife's family, and in the community feel, do, and say about what has happened? Do we have enough financial resources and support from our family and the community to help us adequately? There are other issues too, already been so beautifully. There may be feelings of shame. I had hoped to have a child who would bring joy and prestige to my family and into the world, and now I don't know what's going to happen. There may also be feelings of responsibility and guilt. I do not know what I did wrong that caused my child to have Down syndrome. In addition, although the family needs to seek medical care and other types of assistance, it also needs privacy and to be able to limit who learns about the situation, what they learn about it. From my 33 years of experience in genetic counseling, I believe each of the questions I've just discussed is normal, as are the emotions that they lead to. The emotions can include hope, trust, love, religious acceptance, anxiety, fear, and anger. In other words, parents will experience a mixture of both positive and negative emotions toward the birth of their different child. Both are valid and worth exploring as part of our shared human experience. It's also normal to have several at the same time, including ones such as love and anger that are confusing to feel at the same time. And feelings change over time as the situation changes and as one learns more about what it means and what may occur in the future. However, in my experience, one thing remains constant. Parents and the families are doing the best they can to give their child and all their children, if there are others, as much love and care as they possibly can under difficult, sometimes very difficult circumstances. It's the love, faith, hard work, and courage of families that gives the work I do deep meaning. With all the medical and educational services that are needed, it's difficult for physicians and their staff to help patients understand and manage their social and emotional needs and experiences. The work of Pakistani genetic counselors practice in the United States, and as I've learned so well today, of those working with the KDSP, the work of Pakistani genetic counselors who practice in the United States and provide genetic counseling in Pakistan remotely, and the wonderful work of those of you who are in the KDSP is immensely useful. I hope these comments have been helpful, and I welcome questions and discussion. And I really think it's in the questions and discussion that we can fill out more of what has been presented around these issues today. Thank you.
Thank you very much, Jon. Now I will take a chance to translate some of this information just so that our Urdu speaking participants can also benefit from what you said. सबसे पहले तो मैं जॉन का उर्दू में भी शुक्रिया अदा करना चाहूँगी. ये हम सब के उस्ताद हैं. ये इन्होंने जो किताबें लिखी हैं और जो उन्होंने बहुत ही शुरू में जेनेरिक काउंसलिंग की फील्ड के लिए काम किया है, वो एक जैसे फील्ड का वालिद या बाप होता है, उस तरह से उन्होंने हमें सबको पढ़ाया है, किताबें लिखी हैं. तो इनका यहाँ आज मौजूद होना हमारे सबके लिए बहुत बड़ा एजाज़ है. तो इसके लिए मैं उर्दू में भी इनका शुक्रिया अदा करना चाहूँगी. तो हम आज की जो जॉन ने बातें की हैं, इनमें से कुछ तर्जुमा मैं करूँगी, कुछ अपने एक्सपीरियंसेस शेयर करूँगी जो मैंने देखा है पाकिस्तान में, और आप लोग भी आपने भी एक्सपीरियंस किया होगा, आपने भी देखा होगा. तो जब डाउन सिंड्रोम वाले बच्चे की पैदाइश होती है, खासतौर पर पाकिस्तान में जहाँ ज़्यादातर हामला ख़वातीन को नहीं पता चलता कि उनके यहाँ बच्चा होने वाला है जिसको डाउन सिंड्रोम होगा, तो उनकी ज़िंदगियाँ काफ़ी तरीके से बदल जाती हैं जब उनको पता चलता है कि उनके बच्चे को डाउन सिंड्रोम है. बहुत सारे सवालात पैदा होते हैं, बहुत सारे जज्बात पैदा होते हैं, जो मैं पूरी लिस्ट तो बताऊंगी आपको, लेकिन क्योंकि आप वालिदैन हैं, क्योंकि आप केयर टेकर्स हैं, क्योंकि आप डॉक्टर साहिबान हैं, आपको जितना अच्छा पता होगा वो शायद मुझे उतना अच्छा पता नहीं होगा. लेकिन कुछ सवालात ऐसे हो सकते हैं, मिसाल के तौर पे अब किस डॉक्टर को हमको दिखाना पड़ेगा, कौन सी सर्जरी करवानी पड़ेगी, हमारे बच्चे का मुस्तकबिल क्या होगा, क्या इसकी आइंदा आने वाली ज़िंदगी वैसी होगी जैसे हमारे मुख्तलिफ बच्चों की है, हमारे घर वाले क्या सोचेंगे, हमारे ख़ानदान वाले क्या सोचेंगे, हमें किसको क्या बात बतानी पड़ेगी, क्या ये स्कूल जाएंगे, क्या ये काम करेंगे, क्या इनकी शादियाँ होंगी. इसके अलावा डाउन सिंड्रोम क्या हमारी गलती है, वालिदैन अपने आप से पूछ सकते हैं कि क्या ये हमने कोई ऐसी कसूर किया है जिसकी वजह से हमारे बच्चे को ऐसे डाउन सिंड्रोम हो गया है. इसके अलावा ये भी सोच सकते हैं कि ऐसा तो नहीं है कि हमने कोई दवाई ठीक से नहीं खाई, ऐसा तो नहीं है कि खुदा ना खास्ता कोई हमसे गलती हुई है जिसकी वजह से ऐसा हुआ है, क्या हमने दुआएं सही से नहीं मांगी, क्या हमने पूरी तरीके से तवज्जो नहीं दी. तो बहुत सारे इस तरह के सवालात आ सकते हैं. कुछ बात मजहबी तरफ से भी हो सकती है, क्या कोई खुदाई खफकी है, या ये क्या मुझे सवाब मिलेगा क्योंकि मुझे एक अपॉर्चुनिटी मिली है, मुझे सवाब कमाने का टाइम मिलेगा. इस तरह की बातें भी आती हैं दिमाग में. तो जज्बात जो भी वालिदैन के होते हैं वो बे इंतहा कुदरती जज्बात हैं. ये ऐसे हर वालिदैन जो अपने बच्चों का बेहतरीन मुस्तकबिल चाहते हैं, सिर्फ वही वालिदैन होते हैं जो अपने बच्चों के मुतालिक अच्छा सोचते हैं या अपने बच्चों की फिक्र करते हैं कि उनके आइंदा आने वाले मुस्तकबिल में क्या मैं वही चीज़ें इनको दे पाऊंगी, या क्या ये अपनी ज़िंदगी पूरी तरीके से जी पाएंगे. ये बहुत ही अहम सवाल होते हैं और सिर्फ बेहतरीन वालिदैन इस तरह के सवाल पूछते हैं. तो जेनेटिक काउंसलर जो होता है उसका क्या काम होता है? जेनेटिक काउंसलर का काम एक तरह से आप ये सोच लें कि ये होता है कि सबसे पहले तो वो बिल्कुल गौर से और पूरी तवज्जो से अपने जो उनके पेशेंट्स हैं या उनके क्लाइंट्स हैं या उनके जो बच्चे हैं जो डाउन सिंड्रोम है या उनके जो पेरेंट्स हैं, उनकी वो पूरी तरीके से गौर से सबसे पहले तो उनकी बातों को सुने, और अगर उनको रोने के लिए कंधा चाहिए शुरू में तो वो भी फराहम करें, और अगर उनके कोई और सवाल आते हैं भले वो मुस्बित हों या वो मनफी हों यानी कि पॉजिटिव हों या नेगेटिव हों, चाहे वो अनअप्रोप्रिएट भी हों, तो भी वो उस तरह से सवालों को एक्सेप्ट करें और उनका जवाब दें कि बिल्कुल जैसे आप किसी और डिफरेंट क्वेश्चन का जवाब देंगे. तो फिर अगर वो चाहें तो वालिदैन को पूरी तरीके से इंफॉर्मेशन दें जो भी आपके पास मौजूद है कि तिब्बी या मेडिकल डॉक्टरों को किस किस को दिखाना होता है, या किस तरीके से थेरेपीज करवानी होती हैं, या किस तरह से इनको भरपूर जिंदगी हम फराहम कर सकते हैं. इसके अलावा एक बात आपने देखा होगा, गौर किया होगा कि हमारी इस कॉन्वर्सेशन में हमने बहुत सारी परसेंटेजेस की बात की है कि 4% का ये हो जाता है, 10% का ये हो सकता है, 99% का ये हो सकता है. लेकिन एक चीज़ जो हम तमाम जेनेटिक्स के डॉक्टर और जेनेटिक काउंसलर्स का एक चीज़ पे जो 100% मुत्तफिक यकीन है जो हमारा, वो एक बात पे ये है कि किसी वालिदैन का कभी कोई ऊंच कोई नीच, कोई दवाई ना लेना या दवाई का ज्यादा ले लेना या सही से दुआओं का ना करना या करना, कोई इनमें से कोई भी ऐसा अमल नहीं है जिसकी वजह से बच्चे को डाउन सिंड्रोम होता है। डाउन सिंड्रोम एक बेइंतहा कुदरती नेचुरल चीज़ है जो बच्चे में आने का हर वालिदैन जब भी वो प्रेग्नेंट होते हैं चांस होता है। हम जब भी बच्चे पैदा करना चाहते हैं उसको बीमार होने के थोड़े बहुत इम्कान हर बच्चे में होते हैं। तो इस चीज़ बस एक चीज़ है जिसमें हम बेइंतहा मुत्तफ़िक हैं। तखलीस और साहिल की हमने कहानी सुनी, हमें पता चला कि वो कितने रेजिलिएंट हो सकते हैं। और ये मैं अपनी तरफ से एक बात ऐड करना चाहूँगी कि बहुत दफ़ा ऐसा होता है, और ये हमारे डॉक्टर साहिबान भी इस चीज़ को कंफर्म करेंगे और तस्दीक करेंगे कि बहुत सारे पेरेंट्स, वालिदैन, बच्चे खुद अपनी बीमारी, अपने हालात पे एक्सपर्ट्स हो जाते हैं। वो हमें जितना सिखाते हैं शायद हम उन्हें उतना नहीं सिखाते हैं। तो एक तरह से ये एक गिव एंड टेक है, या ये एक बैलेंसिंग एक्ट है जो हम उनसे सीखते हैं, शायद किसी और से नहीं सीख सकते। तो उसके लिए हम आपको बहुत शुक्रिया अदा करते हैं, KDSP का बहुत शुक्रिया अदा करते हैं, PSMG का, डॉक्टर वायल का और तमाम प्रेजेंटर्स का बहुत शुक्रिया अदा करते हैं। और इसके बाद हम सवालात का सिलसिला शुरू कर सकते हैं। Over to you, Myla.
Thank you so much, Aisha. Thank you for that excellent translation into Urdu and your comments. And Dr. Weil, your comments are always well received. Thank you so much for adding those. So before we go to the question and answers, I am going to see if Dr. Kirmani would like to say anything, or if he has any comments. We would really like to hear from him. We are honored that he is here today in the audience because, like Dr. Ajaz mentioned, he is the expert in Down syndrome in Karachi, and he has a Down syndrome clinic. So Dr. Kirmani, are you willing?
Thank you so much, Myla, and thanks to everyone for sticking around for so long, and thanks to our colleagues in the US who have taken out a Sunday morning to do this for us. I think the only thing I'll add is that KDSP has really changed my perspective on Down syndrome. And I came from one of the best hospitals in the world, Mayo Clinic. And, so I thought I knew everything about Down syndrome, and I just thought it would not be possible to deliver the same type of care. So when I landed on the ground here in a few months, that's when KDSP was just born. It's 2014. And, I just thought that, okay, the families who are going to have a child with Down syndrome are just going to have huge challenges, and we better give them a reality check. And if we give them too optimistic of a picture, then they're just not they're going to have major disappointments later on. And so we better be very realistic and just don't give them too much hope. Well, here comes KDSP and completely raises the bar on what one can do in Pakistan with Down syndrome, and they just refuse to take no for an answer. Every child anywhere in the world deserves the best care, regardless of whether they're in Pakistan or in Minnesota or anywhere else in the world. And, that was just a huge reality check for me, saying if these guys are demanding it, then it is up to us to provide that. And it's been a wonderful journey for me for the last 8 years now to be associated with KDSP and to see how that, not only just raising the bar, but actually delivering what they promise. And it's been teamwork with multiple people involved, lots of families, lots of advocacy like you heard today, and a lot of very well-meaning community members, some who had personal connections with Down syndrome, but many others who did not. And so I think when you start something that resonates and that is a good example, people will gather around and help you, and help will come from many different quarters, like it is coming right now. People have dedicated 2 full hours of their lives to help improve things in Pakistan with regards to Down syndrome. So this is what we've seen, and it's just a wonderful journey, and I hope that many other people will join in, especially the local people who are tuned in today, because I the lack of awareness, as Sila's mom pointed out, is still a very big issue. Even just yesterday I was counseling a family who just had a newborn who had Down syndrome, and they came from another hospital, and they said the person who transferred the baby here gave them some parting advice that don't have a lot of hope and don't think that this child will, and even if people tell you to put them in a school with other children, don't do that because they'll always feel very bad about themselves. So just keep them at home and just take care of them at home. So this was, this was just yesterday. So it's just amazing how much more work we need to do to raise awareness, but I think we're all part of the same mission. And I'm so glad that the whole world is coming together for the children of Pakistan to do this. So thank you very much.
Thank you so much for those comments. And I feel like everyone in the audience today really appreciated all of the work that KDSP is doing. So Samar and Zainab, thank you so much for sharing that. And of course, Sila's story as well, really, like I said before, has pulled on everyone's heartstrings today, and just so commendable, everything her mother is doing. So we have hit 2 hours. So like Dr. Kirmani said, yes, it has been exactly 2 hours now since we started. So I don't want to take any more time, but if there are pressing questions, maybe we can get to a couple of those before we sign off, like in the next 5 minutes or so. I know that some of the questions were already addressed in the chat. Thank you for Ambreen and Dr. Kirmani and everyone who addressed those questions. So if there are any questions, maybe you can raise your hand or type them out, and in the next few minutes, we can wrap it up. Or comments. And it's okay if there aren't any. That's perfectly fine. I've been taught to count to 10 after I say, are there any questions? So I did just that. And now I will just thank everyone.
Can we share our website and our email address, Myla, if that was a thing?
Yeah, I mean, our website is psmg.org, and our email address is gcnpakistan@gmail.com. And I think you might be able to see it here. Just a visual real quick of the website and the email address. You can go on our website where you will be able to find recordings of the previous webinars that we have done, and you're able to view them. So if you're interested in any of those topics, please do that. And if you have any questions or comments, you're always welcome to email us at gcnpakistan@gmail.com. And with that, I just want to thank everybody, all of the participants, and all of the members on the panel who presented. This was just a wonderful, informative, emotional session, and I think that everyone benefited from it. So with that, I will say goodbye. Thank you so much. Have a good rest of the week.
Thank you, Myla.
Thank you, Myla.
Thank you very much.